Greetings, everyone. Welcome to today's webinar, Genetic Counseling and Testing, Your Questions Answered. My name is Alex Jobe. I'll be a moderator on today's event. We have some wonderful speakers to hear from today. At this point, I'd like to pass things off to Erin, a genetic counselor at the Heart Institute at Cincinnati Children's Hospital. All yours, Erin.
Welcome, everyone, and thank you for joining us. We're going to start today's webinar, I think, hearing from probably the most important person, Bridget Tenenfeld. She lives here in Cincinnati, Ohio, has worked for 17 years as a special education teacher. She has two children, a son, Corey, who's now 23, and a daughter, Riley, who's now 13. And Bridget will now give us a little bit of perspective about her own experiences with genetic counseling and testing.
Hi, my name is Bridget Tenenfeld. 18 months ago, my husband, he passed away due to a cardiac event. He was healthy, 40 years old. Did not have any prior heart conditions. So in order to get some answers, we had to do a little work. I called the coroner on a daily basis to ask her about results, and they could not answer any questions as to a cause of death. So due to other reasons, I was able to talk to a cardiologist regarding the events that happened with him. He recommended that I request a genetic autopsy, which I did. My request was not granted. The coroner's office stated they were very costly and they were willing to store blood samples for use elsewhere if needed. She finalized the death certificate as cause of death, suspected lethal cardiac arrhythmia. So fortunately, the coroner was able to make some phone calls and put me in contact with Erin. Within a few weeks, I had a sit-down session with Erin Miiller and a cardiologist, Dr. David Spar. Erin put together a family tree of Troy's family to get a picture of the medical history of his family. She was able to come up with a name for what may have caused his death, which was Brugada syndrome. The syndrome was a genetic heart condition that can cause a person to die of cardiac arrest while sleeping and occurs around the age of 40. In order to have genetic testing completed, a person from Troy's family had to have a previous event. So his older brother had had a previous cardiac event 10 years prior to this and currently had a defibrillator implanted, yet no medical diagnosis was ever completed as to why it had occurred. His brother agreed to be tested for the gene in January 2016. The first genetic test was completed through Ambry. This was not paid for through insurance. The first one we did have to pay out of pocket. About 5 weeks later, the results came in, and Erin called to confirm the positive results of the gene SCN5A, which causes Brugada. After the first confirmed gene, we had a meeting with multiple family members with Erin in order to have blood drawn, EKGs conducted to locate other positive family members. Troy's mother, his uncle, his two brothers, a nephew, and my own two children were tested. All of these tests were covered by insurance, which was wonderful. The results only took a few weeks to come back. Through this testing, it was determined that Troy's mother, his two brothers, and his nephew were negative. His uncle and our two children were positive carriers of the gene. Without the genetic testing, we really would never have known that they were carriers. 2 months after the initial diagnosis, in April of 2016, my son was implanted with a cardiac defibrillator, which is the only fix for Brugada syndrome. His uncle, who is a positive carrier also, had his son tested, and he was a positive carrier of the gene as well. He was implanted with a defibrillator in July of 2016. This then prompted that his children be genetically tested, and 2 of them are SCN5A positive as well and under the care of a cardiologist. Last week on April 12th, my daughter, who's 13, was also implanted with a cardiac defibrillator. Since she has the gene mutation, without the genetic testing and the genetic counseling, many more people may have died. The ability to know what you're up against with the genetic testing saved so many people in our family. And that is all.
Thank you so much, Bridget, for your honesty and willingness to share. As I said before, I think the family and patient perspective is the most important, and I know myself and my healthcare provider colleagues, as well as advocacy groups and testing laboratories, are grateful to people like Bridget and others that are kindly and bravely taking the time to share their experiences. It's really how we learn. To shift gears a little bit, I want to talk to you all a little bit about genetic counseling. Some of you may have met with a genetic counselor, some of you may have heard of genetic counseling, but just provide a bit of background so that we're all on the same page. And then I'm going to return to Bridget's family history and touch on some aspects of the genetic counseling and testing process while sort of using her family history and family experience as an example. So we'll talk about how to approach family screening when someone's been diagnosed with an inherited arrhythmia, genetic testing guidelines and indications for different genetic heart rhythm conditions, talk a little bit about genetic testing results and how we interpret those, and we'll share with you all some additional resources about genetic counseling and testing that may be helpful for future reference. So I think the first question is, what can a genetic counselor do for you? Obviously, that's going to be individual and case specific. I think what I want people to know is that genetic counselors are here to listen to you, to answer your questions, to provide guidance, and to help you cope, and they may be an important part of your healthcare team. The first thing that a genetic counselor can do for you is to help you understand your health risks or health risks for your family members based on your family history. That, of course, includes identifying family members that may be at risk for an inherited heart rhythm problem, but also identifying family members that may not be at risk. We can help identify and facilitate appropriate genetic testing. What testing? There is an ever-growing number of options in terms of the type of testing and where the testing can be sent. Who is the best person in the family to test? There are some of these inherited arrhythmia conditions are relatively common, conditions like long QT syndrome, but even for the same condition, the approach to genetic testing may be very different in terms of where to start. We can interpret and explain genetic testing results, and I think at the end of this, I hope you have a sense about the importance of accurate interpretation of genetic testing results, and that it's not always a black and white answer, that it can be a complex process. And again, genetic counselors can provide support and guidance as you process information about family history, about potential risks, and of course can connect you with other resources and support. At the bottom of this page, there's a link. There's a whole host of resources and links at this particular site that was developed by the National Society of Genetic Counselors that provides information about both genetic counseling and testing. So what happens at a genetic counseling appointment? Most often you'll schedule an appointment just like you would any other healthcare provider visit. The length of the visit varies, I think, by counselor, by institution, by indication for the visit. Typically around 30 minutes or 45 minutes would be a good expectation in general. The first thing I do is identify what the patient or family's concerns are. Oftentimes we have that information ahead of time, either from a referring provider or from reviewing medical records, or have communicated with the patient in advance, but I want to be sure I understand the priorities for that particular visit. Most often, the first thing I do is collect a medical and family history. Most often, it's sort of cardiac focused, at least in the setting in which I see patients and families. So sometimes it's disease specific, other times it may be more general. Discuss with patients and families the natural history of genetic conditions. So, what is long QT syndrome? What is Brugada syndrome? What causes it? And you can explain it in hopefully terms that are understandable to the patient. We provide recommendations and options for genetic testing. We can facilitate genetic testing. I typically do it at the same visit. It may be done on a blood sample or more frequently now even on a saliva sample. And then of course can provide genetic counseling resources and additional information on either disease or genetics if that's necessary or of interest. How can you prepare for a genetic counseling appointment? One thing I tell people is to gather some family and medical history information. Sometimes these are things that are commonly shared and talked about among family members. Other times they're not. Sometimes they aren't discussed because it's difficult. Other times they aren't discussed because people don't actually have a good understanding of what maybe their own diagnosis actually is. So things that are specifically helpful would be the specific diagnosis in medical terms, how old someone was when they were diagnosed with that particular condition, what surgeries or procedures were previously done, how old people are approximately now, or how old people were when they passed away. And if someone happens to have medical records, especially in an individual that has a diagnosis or has passed away, that can be really powerful information. I think consider how you might feel talking about your personal or family medical history. There can be things that are difficult to talk about or you might be unprepared to talk about, so considering the kinds of topics that might be discussed. A lot of people bring someone with them to help provide family history information, sometimes a spouse or a sibling or a parent. They can be there not only to provide maybe additional information about the family, but also just to ask questions and provide support during the visit. At the end of the slide set here, there's a group of resources, and there's some excellent family history collection tools and resources available, one through the Surgeon General, and also there's another one specifically through SADS, and so there's some additional resources if you're interested in how to better gather family history information. Sorry guys, just trying to advance to the next slide. Thanks, Alex. So who should consider genetic counseling? Anyone with a diagnosis or family history of a hereditary cardiovascular disease or someone who may have a hereditary heart condition. Even if individuals have had genetic testing previously and they're interested in additional information about that particular test result, that's an excellent reason to seek genetic counseling. Variant interpretation or classification can change as new information becomes available, either in someone's own medical or family history, but also based on what we're learning about normal gene sequences in the general population or what's been published in the medical literature. So I think you should view reviewing those results as something that needs to happen on an ongoing basis. Individuals who have a family member who have a known genetic change and they're interested what their risk might be or in testing themselves, and really anyone who has questions about the risk of heart disease based on their family history. There are genetic counselors all over the country. Many of us specialize in cardiovascular genetics. There's a link to help both healthcare providers and patients and families find genetic counselors. I've included it here at the bottom of this slide. Easy to remember, findageneticcounselor.com. Okay, so now that you have some background on genetic counseling, I wanted to kind of share with you the genetic counseling perspective of Bridget's family experience. So this is the medical history or the family history documented here in a medical pedigree form that I initially documented when I met with Bridget. So for those of you that don't look at these kinds of family trees very often, circles are females and squares are males, and each generation is included on a horizontal line. The bold arrow over here is actually pointing to Bridget. And so, you know, she came to see me, I think really after talking with an adult cardiologist about unrelated things, and had shared her husband's history, and that cardiologist had expressed some concern that there may be an underlying genetic cause that was associated with her husband's death, and had recommended further evaluation. And actually, Bridget, I learned a bit from you about your conversation with the medical examiner. I didn't realize that they had initially told you that a genetic autopsy wasn't possible, but she had contacted the medical examiner's office and then ultimately referred her here. So actually the first person I'm meeting with does not have an inherited heart rhythm problem, is not even at risk for an inherited heart rhythm problem, but she was really the person, I think, to connect the rest of the family with the next step to get some additional information. You know, I think it can be difficult to ask about affected individuals' diagnoses. You know, Bridget shared that her husband passed away while he was resting or asleep. And while those types of questions and reliving those moments are incredibly difficult, they're also incredibly informative and really powerful, especially when thinking about inherited arrhythmias. And just having heard the age of Bridget's husband and the fact that he was resting while he passed away already had I was already thinking about specific things that may be more likely for him. So here are Bridget's two children at the bottom, her son and her daughter. And here's her husband who passed away. And he had three brothers, as you can see here by these three squares. There wasn't a lot of information about her brother's or her husband's twin brother. He lived here in town, but they just weren't in close contact, especially about medical history information. Here's the other brother that had a history of a sudden cardiac arrest and had an ICD in place. And while Bridget, again, had some information, she didn't know exact details, as most people don't, about all of their family members' medical history. And then another brother here who had had a normal cardiac exam recently. In looking at the rest of the family history, there really wasn't anything overly concerning or suggestive of an inherited arrhythmia, certainly no one else with a sudden cardiac arrest or a confirmed diagnosis. So Bridget was able to bring with her some of the medical records from her husband prior to his death. He had actually had cardiac screening that was completed previously. This was primarily done as part of routine screening for a cardiac medical procedure. So he had an electrocardiogram performed about a year before he passed away that showed he had a normal sinus rhythm, but did have evidence of QT prolongation. He had a normal myocardial perfusion scan, which is a screening test to look for evidence of coronary artery disease or like a prior heart attack, and that was also normal. And he actually had imaging of his heart as well at the age of 32 that showed that the heart muscle itself was normal and that the function of the heart was normal. At the time that I met with Bridget, the autopsy had not yet been completed. I did speak with the medical examiner's office and confirmed that there was a blood sample from her husband that had been stored in the appropriate tube in the appropriate way, so that if we wanted to request genetic testing on her husband, we would have that as an option. And the medical examiner had shared with me that the autopsy did not identify a cause of death. So even though we didn't have it in writing, we had some information from that. Later, we did get the autopsy report, and as Bridget said, you know, normal toxicology, normal anatomy, cause of death unknown, suspected arrhythmia. So there were really two conditions that I was most highly suspicious of. The first was this Brugada syndrome, and for those of you that don't know, the name Brugada just comes from the physicians and researchers that described the condition originally. It's cardiac conduction, a problem with cardiac conduction, and individuals are primarily at risk during rest or sleep. It's really unknown how common this condition is. I've heard estimates of around 1 in 10,000. It's relatively rare, but we certainly follow a number of people here with this condition. It can be a very difficult diagnosis to make, so even people that have a known confirmed genetic cause placing them at increased risk for Brugada, only about 30% of individuals will have an EKG finding confirming that diagnosis. So a normal EKG, you know, does not exclude risk or does not rule out a diagnosis. There's other tests that can be done, one called a sodium channel blocker challenge, where they give you a particular medication through an IV and look for the specific Brugada pattern on EKG while someone's receiving that medication. That's slightly more sensitive when making a diagnosis, but isn't routinely done. People can present with signs or symptoms of Brugada at any age, but sort of what you typically see and what's most commonly observed is men in their 30s or 40s. The other condition that we were considering in terms of a potential diagnosis is called long QT syndrome. This is a much more common condition with a prevalence of around 1 in 2,000. It's characterized by specific features, again, on the EKG that show prolongation of the QT interval. And this schematic here kind of displays what we would typically see on an EKG. So you see here what would be seen in an individual without long QT syndrome. And then long QT1, long QT2, and long QT3 are the 3 most common types of long QT syndrome. The most common symptom with this would be fainting or passing out, but the first symptom can be a sudden cardiac arrest. So individuals with long QT syndrome are at risk for fainting, which is syncope, seizures that aren't actually a primary problem with the brain, but is a seizure because of a heart rhythm problem. And then what you see here at the bottom, this TDP, it stands for torsade de pointe, which stands for, or which is a specific kind of dangerous heart rhythm that you can see with long QT syndrome. It's a type of ventricular fibrillation, so a really fast, irregular heartbeat coming from the lower chambers of the heart. So these 2 slides aren't intended to make you experts on these conditions, but I just wanted to provide a little bit of background about what we were considering. So how do you approach family screening? So you know, I met with Bridget. We were concerned about these 2 possible conditions. As you saw from the family history, there were lots of potentially at-risk family members, and we wanted to be able to offer cardiac screening to ensure that other individuals weren't at sort of inherent risk. So when a cardiac diagnosis is known, say someone has known long QT syndrome or known cardiomyopathy, like hypertrophic cardiomyopathy, then we would offer, you know, disease-specific screening. So if someone's at risk for a heart rhythm problem, you would do an EKG or an exercise stress test or a Holter monitor, something to evaluate the rhythm of their heart. If you know that someone's at risk for heart muscle disease, a cardiomyopathy, you would want to do imaging, most often an echocardiogram. If someone's at risk for coronary artery disease because of a family history of high cholesterol, you would do lipid screening. So I try really hard, as well as the team here, to make very specific recommendations based on the information we have available. It's more difficult if a diagnosis has not been confirmed, but I think the family history details can still help guide some screening recommendations. So specifically for Bridget's family, because we were concerned about inherited heart rhythm problems, we recommended really EKG and exercise screening, not any kind of imaging at this point to look for heart muscle disease. It was helpful that her husband had had some imaging of his heart in the past. And usually when we approach screening, we start with the most closely related individuals first, what we call first-degree family members. So that would be someone's children, siblings, and parents. And then based on those additional individuals' results, we would proceed outward in the family. The other thing that we had suggested was maybe that the affected brother of her husband consider one of those sodium channel blocker challenges to further evaluate whether or not he had Brugada syndrome or not. So who to test? Typically the best person to test in the family is someone that has a diagnosis, is someone that's affected. And I find that for patients and families, this can sometimes be not an inherent or obvious point, right? We know so-and-so has this. Why do they need to come in and have testing? I want to know if my child is at risk or if I'm at risk. And the real reason is that if we're testing someone that's unaffected or doesn't have a confirmed diagnosis and the genetic testing is negative or normal, I don't know if that means this would be a family in which we aren't able to identify a genetic cause, or if that truly removes risk for that individual because their affected family member would have had a genetic variant or risk factor that then wasn't inherited. And so really the only way to remove risk from someone is if we know what the specific genetic cause was in an affected person in the family. So whenever possible, and this isn't a hard and fast rule, but it's most often optimal or more informative to test someone who has a confirmed diagnosis of an inherited heart rhythm problem or other genetic condition. In some families, there's more than one appropriate person to test. And so in the case of Bridget's family, we had the option of testing her husband, which is not always the case, but in this circumstance, the medical examiner had saved a blood sample, which is now a recommendation from the National Association of Medical Examiners in certain circumstances to store blood for the potential future use of genetic testing, or what we call a molecular autopsy, which really all that means is genetic testing after someone has passed away. So it was fortunate that we had that as an option. But there was also the option of testing her husband's brother. And while we didn't have complete information about his medical history and diagnosis, I think we were all suspicious that there was likely a link between the two. At the time, it was felt that he may not be interested and might not be likely to proceed with genetic testing. And so we had planned to go ahead with the genetic testing using the sample remaining from her husband. One of the reasons I wanted to test the uncle as well is that, we had a limited amount of blood and DNA on her husband, and I wanted to reserve that, knowing that, the brother we would be able to get more sample from if need be. And also there's a greater chance of insurance covering genetic testing in someone that is still living. So the plan was, at the conclusion of my visit with Bridget, was to test her husband. I had recommended a rather broad gene panel. Most of the time, the way that genetic testing is facilitated for the first time in the family is what we call these gene panels, and all that means is it's a group of genes. It's more than one gene. This panel was 18 genes in particular and included those that had been associated with Brugada syndrome as well as long QT and some other inherited arrhythmias. So that was sort of our approach to testing. If it was a more known or specific diagnosis, there may have been a smaller or more targeted test that we had recommended. So before the genetic testing was actually requested on Bridget's husband, I got a referral actually from her husband's brother's cardiologist. In reviewing his medical records, it confirmed that he had had a sudden cardiac arrest at the age of 38. That event occurred while he was sleeping. The individual now had an ICD and had received one appropriate shock for ventricular fibrillation that also occurred while he was at rest. So this additional information, I think, was increasing the suspicion for Brugada syndrome. He did not have any evidence of QT prolongation upon review of his medical records. So that 18 gene panel was then initiated in Bridget's brother-in-law as opposed to her husband. So what would be the published guidelines for approach to genetic testing in this case and others? And the most comprehensive guidelines that have been published are now a bit dated. They came from the Heart Rhythm Society and the European Heart Rhythm Association and were published in the summer of 2011. And they have kind of a tiered approach to when genetic testing is recommended or may be useful. So genetic testing is recommended in individuals with a suspected diagnosis of long QT syndrome. They provide some specific guidelines about how long the QT interval should be before considering genetic testing. You'll note here that they recommend known variant testing or known mutation testing for relatives if they have a family member with long QT syndrome or Brugada syndrome. That's what this BRS stands for. They do recommend genetic testing for cardiac arrest survivors, with the type of testing to be guided really by the medical evaluation following that arrest. And then again here I mentioned this guideline also supported tissue collection for individuals with sudden unexplained death. The guidelines suggest that genetic testing can be useful for a suspected clinical diagnosis of Brugada syndrome. The genetic testing may be considered if the QT interval is prolonged but not quite as long. And then they don't recommend genetic testing for atrial fibrillation. So this isn't a comprehensive review of all of the guidelines, but just wanted to give you a sense of what they look like. And while the genetic testing guidelines are helpful, I think we interpret these and incorporate these into the context of someone's medical or family history. So we use them as a sounding board. We use them to help facilitate decision making. But in some ways, they don't always apply. Either you don't have enough information about the family history, and the prior published guidelines really don't address what testing, especially given that the kinds of testing that's available has changed so dramatically, even in the past 5 years or so. And of course, the thing I wanted to share is that these guidelines do recommend genetic counseling for all patients and relatives with familial heart disease. So genetic counseling does not equal genetic testing, and even if genetic testing isn't indicated or isn't desired, that there still may be a role or benefit of genetic counseling for you or your family. So the other thing that you should be aware of when going through genetic testing is the yield. So all that means is, how likely is a positive result? What do you think the positive result is if we ordered the test? And of course that varies. It depends on different diagnoses. It depends on an individual's clinical and family history. And usually when I'm talking with a family, I'm giving them a specific likelihood of finding something that's based on what's available in the literature, and then also my gestalt of the medical and family history. And it's often a range. So for long QT syndrome, if we ordered genetic testing, the likelihood that we would find an underlying genetic cause is between 30 and 70%. Unfortunately, for Brugada syndrome, the yield of genetic testing isn't great. It's around 20%. There is data to suggest that if someone passes away suddenly and the autopsy is negative or normal, that about 1 in 4 individuals will have an identifiable genetic cause on a molecular autopsy. I mentioned a few other conditions here, inherited heart muscle diseases, just to give you an idea of kind of the range. One of the things that I talk with families about sometimes in terms of yield of genetic testing is that, again, the yield of some of the cardiac testing isn't perfect either. You know, I mentioned before that doing a screening EKG in someone in whom you're concerned about Brugada doesn't always accurately assess an individual's risk or the presence of a particular disease. So there are lots of reasons that people may consider genetic testing. One would be to confirm a clinical diagnosis. And I think in this family, this was certainly one of those motivations. What was the cause of Troy's passing? You know, why did he die? A family or patient desire to know either the specific diagnosis or who else in the family might be at risk. Understanding what the underlying genetic cause is can also allow you to make an earlier diagnosis and identify at-risk people potentially before signs or symptoms or before a sudden arrest or sudden event. The genetic testing results can, in some cases, guide treatment and intervention. Beta blocker therapy is a common medication that's used for the treatment of most patients with long QT syndrome type 1 and type 2. Things like lifestyle modifications are important for individuals, certain individuals, not everyone, with long QT1 and long QT2. Sometimes competitive athletics or extreme and endurance sports are a high-risk activity for people with this condition. But in general, I think genetic testing is used in conjunction with clinical data to sort of determine the best course of action. So I wanted to share with you the genetic testing results from Bridget's brother-in-law. So this is an actual image or snapshot from the test results. Here is the list of the 18 genes that we looked at. The way I often describe the testing to families is it's essentially like using spell check for a Word document, but we're actually spell checking the DNA sequence, looking for a misspelling or a change that would cause the gene not to work correctly. And all a gene does is make a protein, and then the protein performs the function in the body. So if there's a misspelling, or what we call a variant, in the gene itself, it can cause there to be not enough protein, too much protein, and that's actually the way in which the disease happens. It's the effect of the genetic change on the protein. So you see here that the gene in which a variant was found is SCN5A, and this is a gene that actually is associated with many different kinds of diseases, but is the primary gene associated with Brugada syndrome, and is also the gene associated with long QT syndrome type 3. The variant here, this is essentially the specific address or the location within the SCN5 SCN5A gene in which the change was found in Bridget's family. This term, heterozygous, just refers to the fact that one copy of that SCN5A gene had the typical DNA sequence or spelling, and the other copy of that gene had this particular genetic change. And this variant classification, this particular laboratory was calling this pathogenic. So the terminology, and this is the current recommended terminology for variant classification, but other laboratories may, or even I use different terms too, may call it disease causing, may call it a mutation. All of those things to me essentially mean the same thing, but sometimes there's different words that are used to describe how that variant is interpreted. So what do we know about this particular genetic change, and does it fit with her family? So this exact change has been seen previously in several unrelated individuals with both long QT syndrome and Brugada. It was seen to co-segregate with disease in multiple families. So essentially what that means is in a family with multiple affected people, everyone with disease was tested and had this genetic change, and people without disease did not. And that's a really important piece of information when trying to understand how likely a genetic variant is to be pathogenic. One of the interesting things that has been reported with this exact genetic change is that people had a complex phenotype or complex disease, meaning they had evidence of both long QT syndrome type 3 and Brugada syndrome. So all of this was really fitting very much in line with what we had seen in the family. Large control populations did not seem to have any evidence of this particular genetic change, so we didn't think it was rare, but common in the general population, and there was other functional data that supported the pathogenicity. So I walk you through that just to emphasize how careful we are about interpretation, and that there really was as much evidence as you ever get to really support calling something disease-causing or pathogenic. So we felt that we could use this information to identify other at-risk family members and also remove risk from those people that tested negative. So I just wanted to show you what a Brugada pattern looks like. So this would be a normal presentation on EKG, and what you can see here, this is called the ST segment, is that it's elevated. And I'm showing you that just to point out here, Bridget's children came to be evaluated, and this was her son's EKG. And I've indicated the area here that shows this ST elevation here in V1, which just indicates the specific EKG lead. And so we were suspicious that he likely had Brugada syndrome as well. And then this was her daughter's EKG, which was done the same way. The same day, and while she did not have a Brugada pattern on her EKG, what she had was QT prolongation, as evidenced here, and kind of these late peaking T waves, or the pattern of how this appeared, was suggestive of long QT syndrome type 3. So actually the same day that her son and daughter were in clinic was the same day I had gotten their uncle's or her husband's brother's genetic testing results, and so we were able to kind of give them all of that information in one day. So what now? We identified this particular genetic change. We've done some initial cardiac screening in the family. What are the next steps? So I keep harping on this, but genetic variant interpretation is important, and we had a high degree of certainty that this was disease-causing in the family. We did recommend testing for Bridget's children, even though they had evidence on EKG screening and we were suspicious that they had this genetic change. If one of them by chance didn't have it, it would really change the way we thought about risk in the family, and we might consider actually additional testing in them. But Bridget's husband had other siblings that were potentially at risk, so 2 brothers that didn't have known disease that were at 50% risk to have inherited this particular genetic change. And so now there was this opportunity or a role to kind of start sharing information within the family about who should be screened. And Bridget did a lot of this. I think genetic counselors can try and help by drafting family letters or emails. I think the main thing is that if you have genetic testing or a family member has had genetic testing, you need an actual copy of the test report. All of those details about that SCN5A variant are necessary in order for other people to access genetic testing and be sure they're getting the right genetic test. So back to the family history. just to orient you again here, so here's Bridget, and here's her children. So those individuals that have red around the outline are those that tested positive for this SCN5A gene change, and then those that are shaded in are the ones that had evidence of either long QT syndrome or Brugada syndrome. And so while there certainly were people that were given a diagnosis and have had, interventions including ICDs in a number of people, there were also individuals that tested negative. So this brother here tested negative for this SCN5A gene change, and because he didn't have it, we were able to remove risk from all 7 of his children. The oldest brother also did not have this genetic change, and he had 3 children that would have potentially been at risk but did not need any cardiac screening or genetic testing because we knew his gene status was negative. So this is another common question. The genetic change itself cannot skip generations. However, sometimes the disease presentation appears to skip generations. So you can have a positive genetic result and maybe not have evidence of the condition or not have signs or symptoms. So the presentation may appear to skip, but the actual genetic change itself cannot. And then because of the brother's test results and Bridget's children's test results, even though we never tested her husband, the only way for them to have the SCN5A gene change and their uncle would be for their father to have had this. So we didn't actually even need to do genetic testing in him. He's what we call an obligate carrier. And as you can see from these other red outlines that a number of other family members proceeded with genetic testing. Not all here. Many of these family members live in other states. But sort of the outreach or the impact of that initial testing and diagnosis was pretty widespread. But I think in total, we were able to remove risk and need for ongoing cardiac screening in about 14 people in the family. So just some key points. Genetic counselors are available to help you and your family. They can be an important part of your healthcare team. Genetic counseling does not necessarily equal genetic testing. They're 2 distinct and separate entities, but are often related. The approach to genetic testing is family and person specific. Interpretation of results is complex and requires expertise as well as periodic review. Negative results, unfortunately, don't exclude a genetic cause. The yield of testing is not 100%, so a negative or normal result doesn't mean it's not genetic, and it doesn't mean that family members may not have risk. When possible, family evaluation should proceed outward in a stepwise fashion. It's, I think, important to have an informed approach to screening in family members. One of the things that I always say is that really a lack of knowledge or a lack of understanding about someone's diagnosis or the cause of sudden cardiac death is really what poses the greatest challenge in understanding the potential heritability of the underlying disease in the family. And in fact, you can sometimes provide false reassurance if you do the wrong screening test. A detailed family history is important. Having access to Bridget's husband's medical records and the autopsy report, we wouldn't, have gotten where we were without those pieces of information. And I think there's a real role for all healthcare providers, pediatricians, family physicians, medical examiners in helping identify and refer appropriate families. I think there's other families that have a similar experience to Bridget, but have never had the conversations she's had and really don't have the same level of information about risk in their family. And so getting the right people to the right place, I think, is important and something we still need to do some work on. So here's those resources I mentioned. And with that, I'm going to introduce Ben Feldman. Ben happens to also live here in Cincinnati, and I knew him when he previously worked here at Cincinnati Children's, but he's now currently manages Ambry's general genetics specialist team. And from there, I'll let you take it away, Ben.
Great, thank you, Erin, and thank you for that excellent clinical overview. And thank you especially to Bridget for her willingness to share her heartfelt story. I think we all appreciate her coming on, and I think her case really illustrates the potential life-saving benefits of seeing a person with an expertise in cardiovascular genetics like Erin and potentially following through with genetic testing. So just wanted to thank both of them. Through this portion of the presentation today, I had hoped to give a laboratory perspective on genetic testing and really illustrate how the genetic testing lab is another one of your healthcare partners. In addition to your doctors, nurses, and genetic counselors, we do really try to partner with your other providers that you're seeing to help achieve the most accurate diagnosis and prognosis and treatment options for your family. So I do have one disclosure that, sorry about that. I'm a full-time employee of Ambry Genetics, a commercial genetic testing lab. So today I wanted to quickly go through the test ordering and billing processes and what that looks like from the lab standpoint. I wanted to talk about what types of specimens we can accept for genetic testing from you and your family. I did want to briefly touch on laboratory workflow and what happens to your sample when it gets into the lab. Talk about test results and what you can expect from a reporting process. And then I get a lot of questions in the field on sample and data storage and what does the lab do with my sample. So we'll address that and then address any follow-up from the laboratory over time. So we've got lots of good questions coming in, so I'll try to go fairly quickly here. So in terms of the test ordering and billing process, one major thing to be aware of is that test selection is very important. Your provider has many different options as to which genetic test can be ordered. And so just something to be aware of. Make sure you ask and clarify why your provider is ordering the type of test they are ordering. There's smaller and larger genetic panels out there. We're to the point where we're doing whole exome sequencing. So I think in general, the larger panels give you more genes and provide you with more genetic information, but they are also more expensive and can potentially lead to a higher likelihood for inconclusive test results, which can end up really confusing the issue for you and your family. So genetic counselors have a lot of good expertise in how to interpret these panels, but again, be sure to ask your provider about why they're ordering the tests that they're ordering. And then just in terms of the ordering process itself, so main thing to be aware of here is just to make sure that your provider puts accurate contact information for you and your family on the test order form. The laboratory may need to contact you for billing reasons or for other reasons. So we may reach out to you directly, so make sure that we can get a hold of you. And then you do typically sign the test order form when you order genetic testing or when your provider orders genetic testing. This is a consent for us to bill your insurance company if we're doing direct insurance billing, and we'll talk about that in a minute. It's not a consent to run the actual genetic test itself. That's going to be done by your provider. So we get a lot of questions about that, so just be aware of why you're signing the order form. So in terms of billing, it's everybody's favorite topic when it comes to genetic testing. There are 3 different possible types of bills that can occur. So the first one is institutional insurance billing, where your hospital is sending a payment to the laboratory, and then your hospital is turning around and billing your insurance company or you directly so that they can get payment. Your hospital kind of acts as a middleman in this situation. The second type is direct insurance billing, where the laboratory that's doing the testing itself will bill the insurance company. So your provider will tell you which type of billing your hospital prefers, and then they'll go down that road. The last type of billing is a direct cash or credit card payment to the lab, and I highlight that in bold because at any time you can decide as a patient that you want to do that rather than do insurance billing and kind of take the payment process out of your insurance company's hands. So if you're doing that, you decide. If you're doing insurance billing, your hospital will tell you whether you're doing institutional or direct billing. Next slide. Okay, there. Oh, whoops. Okay, so a few more details on the billing process when we do direct insurance billing with the laboratory. the lab typically performs a benefits check before the test itself starts running. This can be done before or after we receive a sample from you. So what this allows us to do is estimate your out-of-pocket expense before running the test. So our experience at Ambry is that around 80% of patients are coming back at $100 or less out of pocket. So genetic testing is a lot more affordable these days than people realize. It used to be very expensive and not well covered, but it's getting better and better through educational efforts from providers like Erin and through the laboratory. But it is getting a lot more accessible to patients. So definitely ask on how the lab that your provider is using handles that billing process. We have a process where on our order form you can indicate the amount you're comfortable paying without receiving a phone call, and then if the insurance company comes back with a higher amount, we will give you a call and let you know before running the test. And then you do have a right to cancel if that out-of-pocket's too high, but many labs nowadays will also have options for reduced price testing based on your income, your family size, and any extenuating circumstances you have. So if you're comfortable providing this kind of information to the lab, your income and family size, then you do have the options for reduced price testing. So types of samples that you can submit, typically the lab prefers blood samples in a purple top tube, and your provider will usually stock kits for genetic testing from the labs. We can also take saliva now. The key with saliva is that you can't eat or drink for 30 minutes before submitting the sample, but your provider will help you collect that if that's what you would prefer. And most labs also are offering a phlebotomy service now. So if it's difficult to get out of your house to submit a sample, you can typically, they can have a mobile phlebotomy service where they do home draws. You can go to a local lab if you live hours away from where your main provider is and you don't want to drive. There's many different options now for sample collection from patients and family members. So in the unfortunate circumstance where you have a deceased relative, the National Association of Medical Examiners does provide guidelines for the coroners and medical examiners to save a sample from your relative. Unfortunately, those guidelines are not always followed, so as a patient, it is important to advocate for yourself to make sure a sample is stored. Again, the genetic testing labs would prefer blood, 10 milliliters of blood in purple top tubes. So request that your medical examiner that you're working with save that for genetic testing and DNA banking if you're interested. If blood is not a possibility, the lab can now accept frozen tissue. We can accept blood spot cards and paraffin-embedded tissue for genetic testing. So these are all sample types which medical examiners more commonly store than blood, and sometimes it does even allow testing on an individual that's been deceased for several years if these samples are well preserved. So definitely ask your provider about the possibility of doing genetic testing if your relative has been deceased for several years. And then billing for post-mortem testing is typically cash pricing. So very quick, I wanted to touch on what happens to your sample in the laboratory when genetic testing is ordered. And I'll go through this quickly because we have several good questions we want to get to. But I think the main thing is, as Erin said, we check your DNA for spelling errors. We also check it for deletions of entire genes or entire sentences. And so there's a couple different types of platforms that are typically run now. But the main thing you hear a lot about in the media about possible sample mix-ups with labs. Most labs now have multiple checkpoints to ensure sample integrity and ensure that your sample does not get swapped with another patient in the lab. So there's multiple quality control measures put in these days to prevent that kind of stuff. And then in terms of result and reporting, I won't go through this too extensively because Erin touched on this, but there's a lot of evidence that is used to go into interpreting genetic variants. Our challenge is that each patient has many lines of variation in their genetic code, and most of these changes in your genes are completely benign. They're not going to cause disease. But the challenge for us is interpreting which of these rare variants do cause disease and which are benign. So we consider a lot of different lines of evidence, and classifications on variants do change over time. Okay, and then we get a lot of questions about how is my sample stored and how is my data that's generated stored. Genetic testing generates a lot of data. So the lab is required by College of American Pathologists, which is the body that accredits most clinical genetic testing laboratories, to store blood samples for at least 3 months and DNA samples for 2 years after testing. You do have the right as a patient at any time to say, I want the lab to discard my sample. So if you prefer we not keep it, or if you prefer we send it somewhere else for DNA banking, reach out to your provider and they would be happy to set that up. Your de-identified sample, if it is stored in the lab, it can be used for new test development. It can also be used for internal research projects that can help provide other life-saving medical information to other patients. But again, when we use your sample for research projects, you do have the option to consent on the order form whether you do or you don't want to participate in research. And when your sample is used, it cannot be traced. So we cannot trace your data, additional data that we generate from research back to you. Your sample is completely de-identified. And then your data must be stored for 10 years or longer, again, according to the College of American Pathologists rules. But there are strict lab rules about who can access the data, and our employees undergo extensive training as they do at other labs about how and when they can access data and protecting your privacy and confidentiality. So briefly, I wanted to mention that, as Erin said, classifications on your genetic test results can change over time. So typically the laboratory will be following up when that happens with your provider. Again, it's an important reason to provide accurate contact information so we can follow up with you as needed, especially on those variants of unknown significance as we uncover more information in genetics about what those variants mean and how they can affect patients from a clinical standpoint. And then technology always changes in genetic testing, so additional testing may be indicated down the line as we uncover new information about genes. So with that, I'm going to do a few quick questions, and I'll let Alex tell me when we need to end this. Alex, is it okay to do a few questions still?
Certainly. I think we have, we're come to the end of the hour here, so if folks need to get on with their day, you're welcome to do so, but we're happy to stick around and monitor some questions and kind of reply for those that are willing to stay.
Okay, thank you. And again, this will be recorded for those who want to refer back later. So one good question I got that I think Erin would be the best person to field is it realistic to get cardiologists who maybe don't have a genetic counselor to work with to ask more family history questions? And if so, what questions do you think would be most appropriate for cardiologists to ask about the family history to help identify the right patients for a genetics workup?
Well, I think some cardiologists are very good at asking family history questions. Of course, that practice is variable, and I don't quite know how to get them to ask the right questions, but maybe as a patient, as a user of healthcare services, to share the family history information that you know about that you think is important with the cardiologist, and to maybe ask them if there's additional information that might be helpful or might change their recommendations. I think that's that's the way I would go about it. And a lot of it is practice dependent and how much time different providers have and what they're frequently seeing and sort of what their filter and approach is. But I think patients can't advocate for themselves enough in that regard.
Definitely. And so the next question that I had is how can I talk to a genetic counselor if my cardiologist does not have a local one, and does insurance cover genetic counseling visits?
So that's a great question. I'm glad it was asked because I had actually meant to mention this. So I had shared the link for how to find a physical genetic counselor, but there are a couple of organizations that provide genetic counseling by phone, so that may be one option. Informed DNA is, I think, the most robust and established of the organizations that provide telephone genetic counseling. You can also contact a genetic counselor that may be near you, like in a different city but somewhere nearby, and they may know of additional resources that are sort of state specific. So I'm sorry, Ben, the first part of the question was, how do you find a genetic counselor if your cardiologist doesn't work with one, right?
Correct.
Was there another piece? Oh, and does insurance cover genetic counseling?
And does insurance cover, yeah.
Again, I think it's variable, but yes, that's not something that we have difficulty with here, but if it's something you want information about ahead of time, I know here at our institution we provide cost estimates for anyone before the appointment. And so wherever you're being seen, that should be information that you can be provided with ahead of time.
Awesome. And so another question we received was, how can a gene show up in a genetic test but not actually be helpful with the diagnosis?
Yeah, so I think when I think about genetic testing results, I guess not being helpful, that comes in various forms. So I think what I think of most likely is that you find a variant of unknown significance, so a change in a gene where you're not sure what it means. And whenever you have an uncertain result, it really shouldn't be used for any kind of clinical decision-making or shouldn't be used to make medical or screening decisions or recommendations. And, you know, that comes with the territory. So if you find something but it's not helpful, it's likely because we don't know what it means. And I think the silver lining of that is there is the potential for reclassification. So if a variant is of unknown significance now, it may not always be there. It may be that at some point in the future we can say this is benign, this is normal, this doesn't mean anything, or we think this is associated and these are the associated risks. That doesn't happen usually overnight. Usually takes years, but the time to reclassification varies. And some aren't reclassified, but that is the potential.
And I will add to that, a lot of times genetic testing doesn't necessarily help in a diagnosis. Your provider will more often diagnose you with a SAD-related condition on a clinical basis of your, your actual cardiac testing and your symptoms and your family history. But where genetic testing can be really useful is in terms of family screening. So it can help identify patients in your family who are at risk of an inherited cardiac disorder, especially those who have been asymptomatic. And so that's really where genetic testing is most useful. It's in terms of helping with family screening. Okay, so a couple of additional questions here came in. Can you clarify your statement that genetic change cannot skip a generation, but the presentation can? Not sure if that's what you said, but just wanted to...
Yeah, no, I think that is what I said, but I'm happy to clarify.
Okay.
So I think, I guess in the case of Bridget's family, 2 of her husband's brothers did not inherit the SCN5A gene change. And so there's absolutely no reason to test their children because if their parent doesn't have it, there's no way they could pass on the genetic change. So I think that part was potentially clear. The difference would be that some people, when you look at Bridget's family, carry the genetic change but don't have any evidence of Brugada syndrome or long QT syndrome. So they have the SCN5A gene change, but don't actually have a clinical cardiac diagnosis. And so if you're just looking at the family, it looks like the condition skips generations because the penetrance of the genetic change is not complete. Not everybody with the risk factor develops disease. And we really don't have a great understanding of what all of those modifiers are, of what makes someone more or less likely to present to have a sudden cardiac arrest, for example, than someone else when it comes to Brugada syndrome a lot of the times. So I hope that clarifies. My email is at the beginning of the talk. If you would like to reach out to me, I'd be happy to talk further about that.
Yeah, thank you. That's great. And I think one final question here. What are the genetic testing recommendations for families that have short QT syndrome?
Yeah, so I think if I am remembering the HRS guidelines, I included short QT syndrome on the recommendation list. So it can be considered for short QT syndrome. I have seen a few individuals with that clinical diagnosis. The yield of testing is not great. I believe it's between 10 and 20% just off the top of my head. So I certainly think genetic testing should be considered and should be discussed for short QT syndrome. There's the potential to find an underlying genetic cause, and of course a negative result wouldn't change that clinical diagnosis and wouldn't exclude potential risk for other people in the family.
Okay, excellent. I think that about wraps up the questions we had. So really appreciate everyone for joining us today. I hope this was beneficial in terms of kind of elucidating how the current state of genetic testing and genetic counseling and how it works. This webinar will be posted with a permanent link on SAD's website in addition to Ambry's patient website, so you can go back and refer to the information at any time. Alex, am I missing anything?
I think you covered it. Thank you. Excellent. And thanks to all of our attendees today. I appreciate you all taking the time, the great questions that you asked. If you have feedback for us, feel free to reach out. I'm going to post up that resources page just once again here for everyone to see. We breezed through it just a little bit earlier, but just want to bring this back up so folks have that in front of them. That all being said, have a wonderful rest of your afternoon. And again, thanks for joining. Thanks to our speakers.
Thank you.